Imagine like a security system in your house.
Okay.
And, there's no burglar, there are no broken windows, the doors are locked tight, but the alarm is just blaring at 120 decibels.
Right. Absolutely deafening.
Exactly. And it's going off simply because a single leaf brushed against the outside of a window pane.
Wow. Yeah, that sounds incredibly frustrating.
Right. So you try to turn it off, but the keypad is totally broken. You call for help, and the technician looks around your, pristine living room and tells you, well, there's no intruder, so you must be imagining the noise.
Oh, man. Which is such an isolating experience.
Meanwhile, that deafening siren is still going off in your head day after day.
When we apply that exact scenario to the human body, specifically to chronic pelvic and vulval pain, that invisible blaring alarm represents the reality for, well, millions of women.
It really does.
It's this diagnostic landscape defined by murky waters, where the lack of a visible injury doesn't make the agony any less severe.
Which perfectly brings us to the mission for today's deep dive. Because you, our listener, reached out with a very specific, highly requested topic.
We got a lot of questions about this one.
So many. You wanted us to cut through the marketing buzz surrounding a treatment called the O-shot.
Right, which lifestyle media sometimes labels as the vampire vagina treatment.
Yeah, that's the one. And the core question you asked us to investigate is, can this regenerative treatment actually help with a severe, frequently misunderstood condition called vulvodynia?
And to give you a really comprehensive answer, we've assembled a robust stack of clinical sources today.
Oh, we definitely brought the receipts.
We did. We're looking at the National Clinical Guidelines from the British Association for Sexual Health and HIV, alongside protocols from the Vulval Pain Society.
And we didn't stop there. We're also analyzing a brand new 2025 randomized controlled trial.
Right, the one published in the journal Frontiers in Medicine.
Exactly, and we're cross-referencing that with real-world clinical data from specialized women's health practices, like the Dartford Clinic over in the UK.
So our goal today is to really separate fact from fiction here.
Yeah, we need to find out exactly how this blood-based treatment works biologically,
Right, like what the clinical data actually says about its efficacy for chronic pain.
And ultimately, whether it is a legitimate tool for someone dealing with vulvodynia rather than just like an anti-aging aesthetic trend.
I think the best place to start is by defining the enemy itself.
Makes sense. Let's lay the groundwork.
Right. So if we consult the baseline definition from the International Society for the Study of Vulvovaginal Disease, vulvodynia is characterized as chronic vulval discomfort that persists for more than 3 months.
But the sources make a major point of saying this isn't just like a mild irritation.
Oh, absolutely not.
I mean, patients describe this as a severe burning sensation, an extreme rawness, or literally like a knife-like pain.
Yeah, it's debilitating. And the reason it gets dismissed so often by doctors is that this pain occurs in the complete absence of any relevant visible findings.
Right. The doctor looks, and there is no bacterial infection.
No thrush.
Right. There is no active skin disease like lichen sclerosus to point to.
Exactly. And within that clinical definition, we have to distinguish between two distinct subtypes.
Okay, what's the first one?
The first is unprovoked vulvodynia. This is generalized, meaning the pain is occurring constantly, regardless of activity or touch.
So the patient could literally just be sitting still and the pain is present.
Yes, exactly. And then the second subtype is provoked vulvodynia, which is often localized to a specific area called the vestibule.
Which is why it's also called vestibulodynia, right?
You got it. And here, the intense pain only flares up with touch, pressure, or penetration.
So that could mean during intercourse or when inserting a tampon?
Or, honestly, even just from the friction of wearing tight clothing.
Wow. Okay, so going back to that broken alarm system analogy from earlier.
Yeah.
If there is no infection and no visible skin damage, what is actually causing the siren to go off?
Well, the latest medical guidelines point toward a maladaptive nervous system.
Meaning the system itself is broken.
Essentially, yes.
Yeah.
The body gets trapped in this loop of abnormal central sensitization. Like, let's say a patient had a severe yeast infection 5 years ago.
Okay.
The infection was treated and cleared up perfectly. However, the nervous system in that localized area never actually stood down.
It's still fighting a ghost.
Exactly. The spinal cord and the local nerve endings underwent a plastic change. They became hyperexcitable. So they just keep firing pain signals long after the initial threat is gone.
So the wiring itself fundamentally changed its baseline sensitivity.
Right. And furthermore, researchers have identified site-specific inflammatory responses that are playing a massive role here.
Okay, I saw the alphabet soup of chemicals mentioned in the research regarding this.
The fibroblasts, yeah.
Yeah, exactly. When scientists isolate fibroblasts, which, just to be clear, are the cells that make up structural connective tissue from the vestibule of patients with provoked vulvodynia, they find something crazy.
They find these cells are completely hypersensitive compared to healthy tissue.
Right. And the research specifically mentioned IL-6 and PGE2.
Yes, those are the big ones.
So if I'm the tissue, what are those chemicals actually doing to me?
So think of PGE2 or prostaglandin E2 and IL-6 interleukin-6 as, like, chemical flare guns.
Okay, flare guns.
Right. When those fibroblasts get even slightly agitated, they shoot off copious amounts of these pro-inflammatory mediators,
Just flooding the area.
flooding it. These chemicals saturate the local nerve endings, basically instructing them to stay on extremely high alert.
Oh, wow.
Yeah, the tissue is effectively bathing its own nerves in a chemical cocktail that lowers the threshold for pain.
So a light touch that should just register as normal pressure is interpreted by the brain as a searing burn.
Exactly. It's a massive overreaction by the nervous system.
Okay, so if standard medicine knows that this localized chemical fire and this nervous system malfunction are happening,
Right.
how do they typically approach turning off that alarm? Like, what is the standard playbook before a patient ever even hears the term "oh shot"?
Well, the established guidelines treat vulvodynia as a complex chronic pain syndrome.
Which means it's not a quick fix.
Not at all. Because it involves the nervous system, local tissue, and, the psychological burden of chronic pain, the strong recommendation is a multidisciplinary team approach.
Meaning a gynecologist alone usually isn't enough.
Right. The team ideally includes a pelvic floor physiotherapist, a pain management specialist, and a psychologist.
Let's look at the physical interventions in those guidelines, because honestly, looking through them, it seems like an arduous process of trial and error.
It really is.
What is the very first line of defense?
Usually it starts with systemic pain modifiers. Doctors frequently prescribe tricyclic antidepressants, like amitriptyline.
Wait, antidepressants?
Yeah, I know it sounds strange, but they are not prescribing this to treat clinical depression.
Okay, so what's the goal then?
In very low doses, like starting around 10 milligrams, and slowly titrating upward, these specific drugs can cross the blood-brain barrier and act as nerve pain blockers.
Ah, okay, so they're targeting the nerves directly.
Exactly. They dampen the transmission of those overactive pain signals.
And what if that doesn't work?
If amitriptyline is ineffective, the next step is often an anticonvulsant medication, such as gabapentin or pregabalin.
Which are usually used for seizures, right?
Right, but here they work on different calcium channels in the nerves to achieve a similar dampening effect on the pain.
Okay, but beyond swallowing a pill to block the nerve signals globally, what are they doing for the actual localized pain down there?
Topically, the go-to is usually a 5% lidocaine ointment.
Just straight up numbing it.
Yeah, the goal there is straightforward. Apply a numbing agent directly to the vulva to temporarily block the peripheral nerve endings from sending the signal in the first place.
And alongside that, physical therapy is considered a cornerstone treatment, right? Especially for provoked vulvodynia.
Oh, absolutely.
Because, chronic pain in the pelvis doesn't just stay in the nerves, the muscles react to it.
Very much so. Think about it. When you are in constant pain, your pelvic floor muscles subconsciously clench to protect the area.
It's like bracing for impact.
Exactly. And over time, those muscles go into a chronic, rigid spasm.
Which probably hurts even more.
It does. Ironically, it causes even more pain and actually cuts off healthy blood flow to the tissue.
So what do the physiotherapists do?
They use techniques like biofeedback or specialized vaginal trainers to teach the patient how to consciously release those gripping muscles.
And if the muscular spasm is incredibly stubborn?
If it's really resistant, clinics will turn to Botox injections.
Wait, injecting Botox into the pelvic floor, like the wrinkle stuff?
Yes, exactly the same stuff. By injecting the botulinum toxin into these specific hyperactive muscles, it paralyzes them. Yeah, forcing a relaxation of the spasm and blocking local pain transmitters.
And does that actually work?
Clinical studies indicate it provides significant relief for up to 70% of women.
Okay, that's decent.
It is, but it usually only lasts for about 3 to 4 months before needing to be repeated.
I see. And then, lurking at the very end of the guidelines as the absolute last resort is surgical intervention,
Right, the modified vestibulectomy.
which is where a surgeon physically cuts out and removes the hypersensitive tissue altogether.
Yeah. It is a highly invasive option reserved only for severe, localized, provoked vulvodynia that has failed every other conservative measure.
So, looking at this entire playbook,
It's a lot.
you take pills that alter your brain chemistry, you apply numbing creams, you paralyze muscles with Botox, or you physically cut the tissue out.
Yeah, that sums it up.
Are any of these actually fixing the broken alarm system, or are we just like throwing heavy blankets over the siren to muffle the sound?
You know, that frustration you're identifying is exactly what drives the search for alternatives.
Because these sound exhausting.
They are incredibly taxing on the patient's daily life. Medications like amitriptyline and gabapentin carry a heavy burden of systemic side effects.
Like that.
Patients report profound drowsiness, intense brain fog, severe dry mouth, dizziness, and unwanted weight gain.
So they're trading localized pain for just like complete systemic exhaustion.
Exactly. Even the lidocaine cream isn't a walk in the park.
Oh, really? I thought it was just a numbing cream.
Well, the guidelines note that applying the numbing ointment can often cause a severe burning sensation for several minutes before the numbing effect finally kicks in.
Oh, that is cruel. Putting a burning cream on an already burning area.
It's tough. The reality is that traditional pharmacology is currently focused on management, not regeneration.
And that lack of satisfactory side effect-free relief that actually addresses the tissue quality is the catalyst bringing us to regenerative medicine.
Spot on.
So, if standard medicine is giving these women heavy sedatives to muffle the alarm, what happens when a clinic attempts to rewire the alarm system entirely using the patient's own blood?
Now we're talking about the O-shot.
Exactly. Clinically referred to as vaginal PRP or platelet-rich plasma. How does a clinic actually extract and utilize this?
Well, the procedure itself is surprisingly fast, typically taking only 30 to 45 minutes from start to finish.
Oh, that's pretty quick.
Yeah. The collision begins with a standard venous blood draw from the patient's arm.
Just like a normal blood test.
Exactly.
Huh.
They take a very small volume, usually between 10 to 20 milliliters.
Okay, barely anything.
Right. That vial of whole blood is immediately placed into a specialized centrifuge.
To spin it around.
Yes. The machine spins the blood rapidly for about 10 to 15 minutes, and the centrifugal force separates the heavy red blood cells at the bottom from the liquid plasma at the top.
And the platelets are in the plasma.
Suspended right in that plasma is a highly concentrated layer of platelets.
And once they have isolated that concentrated liquid gold, as some clinics call it, what is the actual delivery method?
So a high-strength topical numbing cream is applied to the vulval area.
Crucial step right there.
Absolutely. Once the area is anesthetized, the clinician uses very fine needles to inject the concentrated platelet-rich plasma directly into specific areas of the vulva, clitoris, and anterior vaginal wall.
Okay, hold on.
Yeah.
You were telling me a woman is experiencing knife-like pain, maybe a 10 out of 10 on the pain scale, from something as light as a cotton swab.
Right?
And the proposed solution is to take a needle and inject liquid directly into that hypersensitive area.
I know.
That sounds incredibly counterintuitive, if not torturous. How is that considered a valid biological solution?
It is a profound paradox to ask a chronic pain patient to endure an injection in their most painful area.
Seriously.
But the clinical justification relies entirely on the biological why behind the platelets.
Okay, explain the biology then.
In human biology, platelets are the body's first responders to any site of injury.
Like when you get a cut and it scabs over.
Exactly. When they're concentrated and injected into tissue, they release powerful autologous growth factors.
Let's break down those growth factors because the literature focuses heavily on two of them, VEGF and PDGS.
Yes, those are the key players.
If we translate that out of the medical jargon, what are these molecules actually doing once they are inside the damaged vulval tissue?
So VEGF stands for vascular endothelial growth factor.
Okay.
Think of VEGF as the body's master architect for plumbing.
Plumbing.
Yeah, it promotes angiogenesis, which is the literal creation of brand new blood vessels.
Oh, wow.
In tissue that has been starved of oxygen due to chronic muscle spasms, like we talked about earlier, VEGF builds new pathways to flood the area with fresh, oxygenated blood and nutrients.
That makes total sense. And the second one, PDGF.
Platelet-derived growth factor. If VEGF is the plumber, PDGF is the structural engineer.
Nice analogy.
Thanks. It triggers cell proliferation and stimulates fibroblasts, those same cells we mentioned earlier that were misfiring.
Right, the ones shooting off the flare guns.
Exactly. It stimulates them to start synthesizing brand new collagen type 3.
So it's rebuilding the area.
It essentially tells the tissue to stop firing distress signals and start rebuilding a robust, healthy cellular matrix.
And the sources place a massive emphasis on the safety profile of this process compared to the standard playbook.
Oh, the safety profile is incredible.
Because the treatment uses the patient's own biological material, right?
Yes, the definition of an autologous treatment. There is virtually zero risk of an allergic reaction, immune rejection, or cross-contamination.
Because your body obviously recognizes its own plasma.
Precisely. When patients weigh that safety profile against the systemic brain fog of gabapentin or the risks of synthetic hormones.
The appeal of PRP becomes highly logical.
Very much so.
But, I mean, rebuilding structural collagen and sprouting new blood vessels sounds like a fantastic anti-aging pitch.
It does.
It makes perfect sense for skin rejuvenation. But does building new collagen actually stop a nerve from misfiring?
That's the million-dollar question.
Right. Let's look at the concrete clinical evidence. Does the O shot genuinely alleviate the knife-like pain of vulvodynia?
To answer that with rigor, we turn to the 2025 randomized controlled trial published in Frontiers in Medicine.
Okay, let's get into the data.
This trial focused on a cohort of 66 postmenopausal women. These women were suffering from vulvovaginal atrophy.
Which is a condition where the sudden drop in estrogen causes the vulval tissue to become incredibly thin, dry, and fragile, right?
Yes, leading to severe, provoked burning and pain.
The design of this study is what really makes it so fascinating to me. They didn't just test PRP in a vacuum against a placebo.
No, they didn't. They divided the patients based on clinical resistance.
Meaning what?
So 36 of the patients received standard topical estrogen therapy. The other 30 patients were assigned to the PRP group.
And the crucial detail here is that the women in the PRP group were specifically selected because they had already tried standard topical estrogen and completely failed to get any relief.
Exactly. They were classified as non-responders.
These were women at the end of their rope for whom the standard frontline treatment had already proven completely useless.
Yep. So the researchers administered one PRP injection per month for 3 consecutive months to that specific group.
And how did they track if it was working?
To measure the outcomes objectively, they utilized standardized, peer-reviewed questionnaires at multiple intervals up to week 12.
Like the FSFI.
Right, the Female Sexual Function Index, which measures various domains of sexual health.
And they also used a VAS, a visual analog scale.
Yes, which simply asks the patient to rate their specific pain intensity on a sliding scale.
So what happened to the women whose bodies had rejected the estrogen therapy when they reached that 12-week mark?
The statistical analysis showed remarkable improvements. By the 12th week, the patients treated with PRP demonstrated statistically significant increases in their overall female sexual function index scores compared to the control group.
Wow. And what about the pain specifically?
When looking specifically at the pain metrics on the visual analog scale, the PRP group reported significant measurable reductions in dyspareunia.
Which is severe pain during intercourse.
Yes, as well as significant drops in generalized burning sensations.
That's huge for those women. But let's make sure we present the full picture from the data, though.
Good point.
Because while it successfully reduced the sharp pain and the burning, the trial noted a specific area where the PRP did not outperform the baseline.
Right. The study was very transparent that there was no statistically significant improvement in the sensation of vaginal dryness for the PRP group.
So it didn't fix everything.
No. The biological mechanism of generating new collagen and blood vessels calmed the hyperactive pain receptors and thickened the tissue, but it did not magically restore the specific mucosal lubrication that is driven by estrogen.
Ah, okay. So it is not a cure-all for every symptom of menopause.
Definitely not.
Oh.
But it demonstrated a profound, targeted impact on the localized pain pathways.
And we see this exact dynamic echoed in the real-world clinical data provided by specialized UK practices, like the Dartford Clinic.
We do, yeah.
I mean, they treat vulvodynia day in and day out. Their clinical consensus aligns perfectly with the trial. The O-shot supports active tissue healing and drastically reduces nerve irritation by enhancing the physical resilience of the tissue.
Exactly. When the structural tissue of the vestibule is robust, thick, and healthy, the nerve endings embedded within that tissue are physically better protected.
Like adding extra padding.
Right. They're insulated from minor friction. By introducing those growth factors, you are calming the localized inflammatory fire of the fibroblasts.
Giving the nerves a stable environment.
Yes, making them far less likely to misfire those abnormal pain signals.
This brings up a really critical point of clarification for you, our listener, who might be researching this online.
Oh, this is important.
Because the internet is notorious for hyperbole.
It really is.
If someone jumps onto a chronic pain forum and claims they entirely cured their vulvodynia simply by getting an O shot, what is the clinical reality behind that claim?
The clinical reality requires a strict, grounded perspective. Within the broader medical community, utilizing PRP specifically for vulvodynia is technically classified as an off-label use.
Okay, good to know.
Furthermore, no reputable clinician considers the O-shot to be a standalone cure for a complex chronic pain syndrome.
So when a specialized clinic reports that a patient achieved remission or considers themselves cured, what did that protocol actually look like?
It almost universally means the patient utilized the O-shot as a catalyst within a tailored multidisciplinary framework.
Meaning it was part of a bigger plan?
Exactly. A successful protocol looks like a synchronized team effort. The patient receives the PRP injections to actively repair the fragile tissue resilience, build new vascular networks, and biologically calm the localized nerve irritation.
But they don't stop there.
Never.
Right.
Once that tissue is physically capable of being touched without sending a 10 out of 10 pain signal to the brain, the patient immediately begins intensive pelvic floor physiotherapy.
Ah, okay.
The physiotherapist can now effectively work to release the years of chronic muscle spasms that built up around the pain.
And mentally, too.
Right. Simultaneously, the patient might engage in cognitive behavioral therapy to manage the psychological anxiety and the central nervous system upregulation that inevitably comes from living with invisible pain.
Okay, I see. The O-shot isn't the whole puzzle, but for a nervous system stuck in a loop of hypersensitivity, it acts as the crucial corner piece.
I like that.
It breaks the physical cycle of tissue fragility so that the physical therapy and the psychological nerve retraining can actually gain traction and do their jobs.
That is an excellent synthesis.
Huh.
It creates the biological runway necessary for the rest of the multidisciplinary treatments to finally take off.
Awesome. Let's draw all these threads together to summarize today's deep dive for you.
Sounds good.
Vulvodynia is a highly complex, often invisible, and deeply isolating chronic pain condition. It is a genuine physiological crisis where the central nervous system and localized inflammatory cells are caught in a continuous misfiring loop.
And standard treatments have limits.
Right. The standard medical playbook heavily relies on treating the symptoms, prescribing systemic nerve-blocking pills with heavy side effects, applying topical numbing agents, or just paralyzing the surrounding muscles.
In contrast, vaginal PRP, or the O-shot, offers a fundamentally different approach grounded in regenerative biology.
Using your own blood.
Yes. By utilizing a simple blood draw and isolating your own autologous growth factors, clinicians can inject powerful cellular messengers directly into the compromised tissue.
Which is amazing.
It is. This process actively promotes real tissue regeneration, stimulates the growth of new blood vessels, and reduces localized nerve irritation, all with an incredibly high safety profile.
So, while the clinical trials and real-world data prove it is not a standalone magic bullet,
Right.
it has emerged as a highly promising, scientifically backed tool for patients who have found no relief in standard treatments.
Absolutely.
It's a paradigm shift from just snipping a wire to actually attempting to rebuild the broken security system from the ground up.
Which leaves us on the final rather profound question to consider as we look toward the broader horizon of medical science.
Oh, I like where this is going.
If the data shows that we can extract a small vial of our own blood, process it in 15 minutes, and use those concentrated growth factors to essentially reboot and heal a severely malfunctioning hypersensitive pain network in the pelvis,
Yeah.
what are the implications for the future of chronic pain everywhere else in the human body?
Man, it really makes you wonder if we are rapidly approaching a new era in medicine.
I think we might be.
An era where the ultimate, most sophisticated pharmacy isn't manufactured in a lab or found in a plastic pill bottle,
Right.
but is actually hidden quietly inside our own veins, just waiting to be unlocked. Maybe the exact blueprint required to fix our broken systems has been circulating within us all along.
That is a fascinating perspective on the innate healing capacity of the human body, and honestly, a perfect place to leave our discussion today.
Thank you for joining us on this deep dive into the science of regenerative medicine. Keep questioning the standard playbooks, keep looking for the why behind the data, and we will see you next time.